Okay. Hello, hello. So, welcome to Adult Health 1. We're starting off with Chapter 10, Fluid and Electrolytes. This is a tough kind of subject to start off with, but really important. So, you got to bring in your knowledge of A&P, of patho, kind of roll that together to also kind of include the nursing specific stuff. And that's the goal of adult health, to kind of start getting the understanding of that. So, first off, fluid and electrolytes. Um, the fundamental concepts we want to think about with fluid goes back to some A&P and some patho, but um, where is our fluid in our body located? So most of a majority of our weight, our body weight is actually pretty much water fluid, somewhere in the neighborhood, depending on male and female, around 60% of an adult's weight is electrolytes and water. Um, and that can vary. It has multiple factors that can vary, but overall, this is kind of the consensus that's highlighted in your textbook. So, of that 60%, 40% of that is inside the cell, intracellular. Usually that's labeled intracellular fluid, ICF. So, the fluid that's inside cells, and about 20% of that 60% is extracellular. So, that would be any fluid outside of a cell. And so, basically, if you break that down, 10 liters of it's interstitial, which is kind of the fluid that would be in tissues. The other portion of that is our plasma, the fluid that's in our bloodstream that's carrying all of our components, our blood cells, other chemicals, hormones, and then Transcellular would be kind of in between interstitial and the tissue part and plasma, kind of moving what fluid that's always moving. That's all ECF, extracellular fluid. And that accounts for kind of the rest of the liters of that. And there's many factors that can change this. Gender, male and female, are going to have different water body percentages slightly, just because of greater fat content in females. Age, weight, and height are all going to kind of be a factor. And when you hear like intracellular fluid or um, inside cell fluid, is kind of how ICF is intracellular. But if you think of ICF as intracellular, you could also think of it inside cell fluid to kind of help you remember. The intro is like internal, and then extra, if you're extra, whatever the kids are saying these days, that's outside the cell. Um, uh, so moving on. Um, so how do we regulate this fluid that we have inside of us? So just as a quick refresher on kind of some A&P concepts, if you kind of remember the concept of the word concentration, what is that really talking about? Well, concentration is really just talking about the amount of solutes in a given solution. So when you hear solute, that is basically, think of particles or molecules, think of hard things inside a solution. So kind of every solution has solutes in it for the most part. Even the water you drink, it's not completely distilled water or purified water. It has other molecules in it, and that would be the solutes. So um, again, think of kind of mixing a drink too. If you were to mix something to make a shake or something like that, those are solutes being dispersed into a solution. So concentration just means there's this many particles or solutes compared to this much water or whatever the solution is. That's what concentration talks about. So how our body regulates that, a lot of these things happen naturally or are based on our body mechanics, such as hormones and other things, but some of these just happen naturally in the world. So um, overall, we're going to talk about things like diffusion and osmosis. But if you kind of remember, I have a slide coming up on diffusion, but diffusion is just a basic concept of water, or excuse me, of solutes moving. Osmosis is water moving. So we'll talk about that difference. But difference between diffusion and osmosis: diffusion is talking about those solutes, those particles will move to equalize a concentration of something. And osmosis talks about the water will move to equalize a concentration between solutes. And that's what this picture is showing you, because there's a membrane In this case, the picture showing you a semi-permeable membrane, like aka our cell membrane, that allows water through. And so if the concentration of solutes is higher on one side, the goal of osmosis is to move the water to try to equalize that concentration. So if you kind of think of it this way, with a picture they're showing us to describe osmosis here, what they're basically showing you is that you could say whatever 1, 2, 3, 4, 5. We'll just say there's 6% something here, and of solutes or whatever in the solution, and we'll just say there's something like whatever 40% over here. Well, osmosis says this membrane right here allows water molecules through, but it blocks these solutes from moving. So because the membrane's there, it's not going to allow these solutes through, but it will allow water through, like our cell membrane. So water, natural principle of the world we live in, is going to try to equalize the concentrations between these two. So water will flow through the membrane because it's allowed to, and thus make the concentration the same on either side. Now the water level will change, like they're showing in this picture, but now this percentage would basically be the same. However you want to say that, we'll just guess a number. So basically the water is going to move to make the concentration 20% solutes on this side and 20% solutes compared to the water on this side. The concentration now would be the same, and that's what osmosis is doing. It's trying to move from an area of high concentration of solutes to an area of low concentrations and equalize it. The goal is equalizing this concentration. That's what osmosis principle is. Again, same principle as diffusion, but osmosis means the water moves, not the solutes, because there's a membrane that's blocking the solutes from moving, basically. And so some concepts that are also highlighted in the book: hydrostatic pressure. Hydrostatic pressure is based on the pressure under the blood vessels. Specifically, usually we're talking about the capillaries. So the direction of fluid is kind of based on the force the blood is pushing against the capillaries, which is kind of how we get our blood pressure readings. But that pressure is going to cause a concept that's a natural occurrence called filtration, and filter things out through membranes based on higher levels of pressure to low levels of pressure. So hydrostatic pressure is one of the main principles that pushes fluids out in your capillaries into the tissues, like your oxygen molecules and uh, other electrolytes and nutrients the cells need are going to get pushed out by hydrostatic pressure. So some of these other references here: osmotic pressure is basically the amount of hydrostatic pressure needed to stop the flow of water by osmosis. So this again depends on a concentration of solutes. So again, osmotic pressure is a term that's describing this hydrostatic pressure, the amount of hydrostatic pressure needed to kind of slow that flow or stop the flow of water by osmosis. And this is going to depend on this, again, these concentration gradients here. Depending on what the concentration is, for example, if we're talking about capillaries, if the cells have enough, we'll just say um, potassium, then when potassium flows through that area, the potassium is not going to move, and the pressure may push out some fluid. But overall, because the fluid concentrations are the same, osmotic pressure states that even the hydrostatic pressure of the blood vessel, it may not push out that much fluid. The fluid will stay equal or maintain a balance because of the concentration of solutes. So some of the other terms that are on this slide talked about in your book: oncotic pressure is basically a type of osmotic pressure. So osmotic pressure, basically there's two forces that are always kind of in play here. We talk about blood vessels, and we have a slide that talks about it. The forces in play here are hydrostatic pressure of the blood vessel, especially on the arterial side, pushing things out, and osmotic pressure is the pressure of basically forcing things back in, and they balance each other out for what molecules are going to move, what amount of fluid is going to move in and out of blood vessels. And so those are the two forces here: is hydrostatic pressure and osmotic pressure. But onconic pressure is basically a subtype. Onconic pressure is a subtype of, look at it that way. So osmotic pressure, hydrostatic pressure are the main contributors to this. But onconic pressure is like we could indent this, a subtype of osmotic pressure. And what it's doing is onconic pressure basically is talking about any pressure created by usually plasma proteins or any molecule that likes to kind of pull or suck water towards them. So some of you may know what molecule in our blood likes to pull water where it is. Give you a second to think about it. That molecule is albumin. So albumin is the main plasma protein. And so onconic pressure is talking about what forces albumin. I'm not the best speller. You'll learn with me. I'm not the best speller. I can tell you all the smart words in the world, but I'm a nurse first, not the best speller. We'll never want a spelling bee, but that's okay. So albumin is what is the dictator of onconic pressure. So higher levels of the plasma protein albumin are going to kind of kick the scale of the balance of hydrostatic pressure and osmotic pressure and make osmotic pressure win as far as where fluid gets sucked to or pulled to. So hydrostatic pressure is more about the extracellular fluid, the blood plasma pushing stuff out into the tissue. And osmotic pressure is more about pulling fluid back into the bloodstream. And it's mainly because of the amount or force of onconic albumin. Uh, Another word for albumin that they sometimes talk about is onconic pressure. They sometimes call it colloid pressure. Colloid is just another term that basically is talking about albumin. And then something that's not too highlighted in your book, just to kind of highlight something else, is a word called osmotic diuresis. So hopefully you know the word diuretic or the term for the medication diuretic or what diurese means. But diurese means to have excessive amounts of urine outflow. And so osmotic diuresis is basically increased urine output through the kidneys because that fluid is going to follow solutes that suck it basically or pull it. So think of in the case of diabetes mellitus, high levels of glucose. The kidneys are trying to get rid of glucose to bring that blood glucose level down. Water will follow. If I lose sodium for some reason, water follows. If I'm losing protein because of damage to the nephrons in the kidneys, water follows. That's osmotic diuresis. And there are some medications that can cause this. There's one called mannitol. That's not necessarily a need to know, but mannitol is basically an osmotic diuretic that's used more commonly or used rarely, but it's used to treat things like increased intracranial pressure in the brain and stuff like that. But that would be an example of an osmotic diuretic kind of medication. But that's what osmotic diurese or is talking about. So continue the conversation of again the need to know here is some of these definitions. But again, I like to highlight in my classes kind of the three knows of learning. And so need to know is like, hey, this is something that likely will be on your test. It's something that's going to stick with you in the future. Nice to know is something that may or may not really be on your exams for a class, but nice to know means you might see it in the future. It could be useful to you in other classes and your future nursing practice. And then nuts to know is usually things that are very, very specific that can be confusing concepts that, only really smart people doctors and other people that really study this stuff or really need to know, and that's nuts to know. So I'll try to kind of highlight that when I can. So kind of the need to know to summarize this so far is really that the balance here is really we're talking about regulation of fluid. We're talking about the regulation in our blood vessels most commonly because they operate some of the basic fluid movements or movements of anything in our body is the concept of diffusion. You're not going to know that. The concept of osmosis. So, diffusion is movement of fluid or particles or solutes from areas of high to low concentration. Osmosis is the movement of water to areas of high and low concentration of solutes because it wants to equalize it and it's got a membrane in the way. And then filtration is a concept we'll talk about in a minute here of there's the process of nutrients and other chemicals being pushed out of the bloodstream. What kind of maintains filtration is basically this concept of hydrostatic uh, pressure in the blood vessels pushing things out, and the osmotic pressure um, the balance of pushing stuff back in. They're kind of the balancing each other out between the two extracellular fluid compartment of the blood and the intracellular fluid compartments of the cells themselves. So moving on, again, kind of reminding what diffusion means on simple terms is this is just a process like osmosis that occurs naturally in the world. This is the tendency of solutes to move from areas of higher concentration to lower concentration. And this is what it's kind of showing you is that in this cell, there's a membrane that allows whatever molecule this is through, and it's going to allow it through. And so diffusion takes place to equalize the concentration between these two compartments. A great example of this is like a dye tablet, right? If I were to put a tablet of food dye or coloring, it would be a hard compressed tablet. So all the molecules in that tablet are very compact and a high concentration. Well, I put that in a cup of water. The water around that tablet doesn't have any of those dye particles. And so it's going to slowly dissolve. And when it does, it's diffusing those dye particles throughout the water cup and turning it whatever color the dye tablet would be, red or whatever, because they have diffused across that area, that container, and now equalize concentrations of the solute, in this case, the particles that make up the dye tablet. And so again, this slide is kind of talking about the difference between diffusion and osmosis. Again, natural processes that occur in our bodies. Diffusion, solutes or particles, whatever you want to refer to, shift from one part of the other. That would be the dye tablet to equalize concentration. And then osmosis is water shifting to equalize concentrations because there's a membrane not allowing solutes through. And this best example of that is your cell membrane. This talks about the kind of onconic, which again, onconic pressure is just a type or description of osmotic pressure that's specifically talking about the pressure exerted by the protein or other molecules that absorb water in the blood vessel. So onconic was just a type of osmotic pressure. But again, this whole process is highlighted there where the first word is filtration. Filtration is just the movement of water and solutes from areas of high pressure, hydrostatic pressure, to low hydrostatic pressure. So think high hydrostatic pressure, blood vessels because of the heart pumping against the arteries, especially, and then low hydrostatic pressure in the tissues. So basically, hydrostatic pressure is greater than the colloidal osmotic pressure. So they're describing the osmotic pressure as colloidal, which is a term describing the protein pressure. So it overwhelms and filtration occurs, pushes stuff out in the tissues. And then through the middle of a capillary, there's not really any movement. The hydrostatic pressure and that osmotic pressure are equal to each other. And then at the end here, as we get on the other side of a capillary, we turn into venous flow and pressure drops significantly. And so now hydrostatic pressure is slightly lower than basically the pressure that's being pulled by the what they would call again osmotic pressure, the colloidal osmotic, or again you could call this colloidal onconic pressure. Either way, they're kind of synonyms. It's very confusing, but again, think of onconic pressure as the pressure of plasma proteins pulling fluid, and this is a type of osmotic pressure. So basically at the venous end of a capillary here, now the pressure in the hydrostatic pressure in the capillary is now lower than the pressure exerted by the proteins and albumin pulling stuff back in. And so it's going to pull things back in, especially the fluid. So there's no fluid loss, hopefully, during this capillary exchange process. And that's the process that's most hard to understand, but that's the process that's happening every time our blood flows through capillaries. And that's how we exchange nutrients. So keeping just the concept of fluid status, how do we lose fluids? Well, um, there's a lot of ways. Our intake is fairly obvious, drinking it, of course, but also we get a lot of fluid from food, especially fruits and vegetables have a lot of fluid in them. We get a lot of our fluid in our food. Um, and some of the ways that we lose it really have to do with just general uses in metabolic, making proteins, doing normal metabolism things. A lot of the bulk fluid is going to be through urine. Obviously, most urine output would be somewhere in the neighborhood of 1 to 2 liters a day. And then we're going to lose some in our stool, as well as just some things we can't sense. So there's going to be lungs will actually get rid of some fluid a day. Depending on what we're doing, if we were to work out, have increased respirations, that would go more. A lot of our fluid is evaporated through exhaling. And then depends on how much you sweat, that sort of stuff. On that day, we can lose a lot of fluid that way. Let's see. Yeah. So moving on. So example of an average kind of intake and output on a healthy adult. So I and O's are very important for nursing. Those come up a lot. This is something that you as a tech have, if you've worked as a tech, have done before, but this is something that will be important in your nursing career. So this is just very important for nursing. Basically, what I's and O's are just documenting the fluid intake and the fluid output. But when we document this, whether that's every shift, typically that's how most hospitals function, but intake and outputs have to be done every shift, but they can be done more often in ICU settings when there's really acute conditions happening, those sort of things. But this allows us to document trends and kind of keep track of stuff so we can notice um, things before basically the ID problems and provide evidence for those problems, but kind of catch them early or help identify what the problem is. And it's really important in the sense of what intake and output is because the goal of our body, if you go back to A&P and patho, the goal of our body is homeostasis, right? Regulation. This picture is the goal of our body. If we intake 2,600 milliliters, the goal of our body is to only lose 2,600 milliliters. That's kind of the goal. We're going to try to lose exactly what we take in and keep that balance. If that gets out of balance, more output versus more intake, whatever it is, that's when we can have disease crop up or we can have problems. So that's kind of what this is trying to tell us. So I's and O is very important. You need to understand what an I and O is. It's an intake and output documentation, basically. So lab tests for evaluating fluid status. There's several. Labs values can depend on your institution and what textbook they're using to reference. This is the ones we're going to use. Osmolarity basically is kind of a reflection of the concentration of sodium, is what osmolarity says. But osmolarity, this first one can vary depending on if some of the other labs are off, especially creatinine and uric acid can affect osmolarity. But osmolarity is basically, you imagine like how much sodium there is in our fluid in our blood vessels. Because again, you have to remember lab tests are always evaluating our blood levels. That's how we determine things because that's all we can really test with labs. We're drawing blood to do it. Urine specific gravity, and as again, osmolarity is about kind of overall fluid status. Urine specific gravity also about overall fluid status. This is measuring basically the density of our urine compared to water. So just overall what the concentration of solutes are in our urine. So of course we have a specific range. The book I think uses 1.005 to 1.030. Also on this side we have 1.010 to 1.025. So that's the one we're kind of going with here, but it can vary depending on the book. That sort of thing. But this is around the range for urine specific gravity. Again, just measure of concentration of solutes in urine. BUN stands for blood urea nitrogen. BUN and creatinine here are very kind of honed in on. These are measurements of overall kidney function. So osmolarity urine specific gravity is going to talk about concentration of solutes and sodium in our blood. and kind of give us an idea of possible dehydration, those sort of things. But BUN and creatinine are overall going to give us the best guides to kidney function. So if the kidneys are not working well, they're the ones that are supposed to get solutes out in our urine. And if they don't, those toxins, solutes, whatever it is, end up staying in blood. So blood, urine, nitrogen, we get rid of urea and nitrogen through our urinary system. And if the amount of urea in our bloodstream is high, that just kind of indicates kidneys aren't working well. So a normal BUN is 10 to 20 milligrams per deciliter. So if I have a BUN that's high, that would tell me that my kidney status is not working well. Possible dehydration could be some things like that. Same thing with creatinine or creatinine, but creatinine is how I say it, is basically a chemical that gets broken down from muscle metabolism. So muscles doing their thing. And this is usually always cleared by our bloodstream through the kidneys. So if this number is high, then that would indicate that creatinine is not being cleared by our kidneys. And again, going back to this, creatinine is kind of identifying kidney function issues. And this range can vary for some people depending on muscle mass and their body weight, but overall 0.7 to 1.3 milligrams per deciliter is considered kind of the normal range. And then hematocrit, HCT. Hematocrit is a measurement of percentage of red blood cells in our bloodstream. So this one can actually indicate dehydration, or it can indicate a condition called polycythemia, which is too many red blood cells, but it's a good indicator for fluid status because our red blood cells are contained in a big extracellular fluid, container that is our blood. And so if we were to get rid of a lot of fluid, we'd still have the same red blood cells, but now the concentration would be higher. So a higher concentration of these percentages saying there's more red blood cells, that could be dehydration. Or indicator of dehydration, basically. And then men and women tend to have different levels of this. Women have a little bit less blood than men, so the percentages are a little bit different. 42 to 52 for men, 35 to 47%. Again, hematocrit is a measure of percentage of red blood cells. Other blood counts labs, they're not too specific to fluid status. You have definitely your hemoglobin, which is a measure of hemoglobin in the blood, and then just your straight up red blood cell count per, I think, millimeter of, I think, million per deciliter, something like that. So homeostatic mechanisms. These are our mechanisms for maintaining our body's fluid, keeping it kind of in a balance. Figures 10.5 and 10.6 kind of highlight a lot of this, but kidneys, pretty obvious. Kidneys are a huge regulator, probably the number one regulator of our body's fluid balance. The kidneys are that. I'm going to say that again. Kidneys are likely our number one regulator of fluid balance in our body. Heart, blood vessels, they're all about circulating. So issues with the heart or issues with blood vessels means decreased circulation, means fluid status can shift if basically the fluid in our blood's not on a continuous appropriate flow rate, so to speak. It needs to be flowing appropriately. Lungs, again, they remove some fluid through exhalation, so lung problems can kind of mess with fluid status. Our pituitary gland is in charge of releasing ADH. If you remember hormones at all, ADH is anti-diuretic hormone. This is usually constantly released to kind of conserve water because it's in the name of the hormone, ADH, anti-diuretic hormone. Diuretic is something that makes you lose excessive amounts of fluid in your urine. So anti-diuretic hormone, anti is against something. So anti-diuretic hormone wants to do the opposite of losing a lot of fluid, wants to conserve fluid. And its targets usually our kidneys. Our adrenal glands are on top of the kidneys. They secrete aldosterone, which causes sodium to be retained by the kidneys. And when sodium is retained, water tends to follow solutes like albumin and proteins, but sodium definitely sucks water. So how I always learned it with an A&P teacher I had years ago was that salt sucks. So if I hear sodium somewhere, think water is going to follow. And again, these are about maintaining our fluid status. Similar effect as ADH, just does it a different method. Our parathyroid can mess with calcium levels, and that can kind of cause some fluid shifts. uh, baroreceptors, osmoreceptors here. Baroreceptors are about pressure changes, and that can affect our fluid status. And then osmoreceptors are more in line with detecting concentrations of solutes and chemicals, and therefore changing the way the blood vessels act and that sort of stuff to balance that. And kind of uh, the RAA system, renin angiotensin aldosterone system. We'll talk more about that and how that regulates fluid. And then natriuretic peptides, mainly the main one you'll hear about is ANP, atrial natriuretic peptide. This is released by the atria of the heart to mess with vascular fluid status to help control blood pressure. Usually the goal of ANP is to, or the natriuretic peptide is to decrease blood pressure. So let's take a sidebar to the RAA system. This is again known as the renin angiotensin aldosterone system, RAAS or RAA system. The goal of this is to have renin released, which the final goal of this is to kick off the adrenal glands to make aldosterone, which we just talked about. What does aldosterone do? Well, it reabsorbs sodium, thus fluid follows. Maintain fluid status. That also helps maintain blood pressure. Well, how does this work? Overall, kind of the first step is that in our kidneys, we have what's called the glomeralis, and we have arteries that come into the glomeralis. And those arteries have what's called juxtaglomerular cells, some cells that read blood pressure changes. So the need to know from the RAA system is it only responds to drops in blood pressure, because its end goal is to have aldosterone and raise fluid status, thus raising blood pressure. So blood pressure falls, juxtaglomerular cells send out an enzyme called renin. Renin gets converted to angiotensin, that gets converted to angiotensin 1. That enzyme gets converted in the lungs, actually, and that is called ACE, angiotensin converting enzyme in the lungs, converts that to angiotensin 2. Angiotensin 2 is going to go target the adrenals to release aldosterone, salt retention, blood pressure rises. Angiotensin 2 on its own can raise blood pressure. And so this is our mechanism of maintaining fluid status and maintaining blood pressure. Now, that number 3 component, the angiotensin converting enzyme that's in our lungs. Now, you may not have a lot of medications yet, but some of you may have heard of ACE inhibitors. They're a blood pressure medication. They're the prils, lisinopril, enalapril, those guys. This is a nice to know for the future, not a need to know for this class necessarily, but definitely a nice to know for the future and hopefully helpful for farm. But how ACE inhibitors work, their mode of action or methodology is ACE inhibitors block angiotensin converting enzyme ACE in the lungs, so they stop this conversion of angiotensin 1 to 2, thus stopping the process of raising blood pressure. And this is used to control blood pressure. One common side effect, if you know, from ACE inhibitors, or adverse effect, you could call it, is a dry, unproductive cough in the lungs. That's very annoying, and that's because of what it does blocking this ACE inhibitor. It blocks ACE. So anyway, that's a sidebar of a nice to know, but very interesting. But that's the RAA system. Its goal, again, to summarize the need to know, is that RAA system, it responds to only drops in blood pressure coming into the kidneys, into the nephrons. Its goal is to raise it. It uses an enzyme called renin, does a bunch of converting that ultimately will raise blood pressure and target aldosterone to raise fluid status and blood pressure more. So if you were paying attention, what is the primary function of renin angiotensin aldosterone system? So this is what I usually use a lot. I use these guys to kind of help with questions throughout the course. I'm working through my PowerPoints, trying to update my questions, and there'll be a little bit of ongoing process. But for example, what's the primary function of the RA system? So if these are again, when you're looking at questions, especially in the nursing world, even though you're like, I don't know the exact wording is what it is, you have to work with what you're given, right? You cannot think of a question outside of itself, meaning I have to work within the question. So if I have a thought in my head that what the exact answer is and it's not exactly here, I'm going to have to eliminate stuff that can't be it and then pick the answer choice that would be the most sense to answer the question. And the subject of the question is primary function. What does RA do? So I need to know what RA is and what it does. So I'll give you a second. Okay. If you picked number one, you'd be correct. But it doesn't really talk about promoting vasodilation, and that would generally increase blood pressure, which is not a goal of renin. Doesn't talk about heart rate. We don't really talk about urine output too much, but we know that it would likely decrease urine output because it would absorb sodium by getting aldosterone involved at the end of this process, and therefore would actually decrease urine output, raise blood pressure. So it's all about regulating blood pressure and fluid. Some things else to consider about our fluid components: gerontological considerations. So gerontology, again, is the study of kind of the older population. So with fluid status for them, their clinical manifestations of fluid status may be very subtle, hard to detect. And for them, a lot of stuff, infection especially, but also not having enough fluid, severe dehydration can cause confusion, delirium. They don't have as much cardiac reserve, meaning their heart has a hard time functioning when it's stressed versus someone that's younger. They already have usually reduced renal function. So, one of the most common instances of fluid balance issues for geriatrics is going to be dehydration. So, fluid volume disturbances. So, let's talk about the kind of disease processes around fluid volume. So, so understanding IV solutions. So hopefully you've heard some of these before. Um, but basically, what's conversation here is fluid for IV solutions is going to kind of come in three flavors, basically. It's going to be isotonic, hypotonic, or hypertonic. So hypo or hyper, you should know what hypo and hyper as a prefix means, but just to refresh, hypo is low and slow, not enough of something. Hyper is always meaning high or more of something. And isotonic, usually iso something is going to be or idiopathic or something like that. It's like more neutral. So isotonic solutions are all about keeping fluid in the same place, mainly keeping fluid inside the blood vessels. Hypotonic solutions are going to push fluid or pull fluid into interstitial space or probably back into cells. So if you kind of imagine that a hypotonic solution, if we're talking about a person here, hypotonic solution, I can't really draw too well, but hypo is kind of similar to like hippo, if you think of it that way. But hypotonic solution means that someone's going to swell or have edema. I can't draw a hippo. I don't know what that is, but anyway, so hypotonic solutions mean that fluid is shifting into cells and interstitial space. So think of edema, those kind of things. They're going to push fluid out of the blood vessels and make the cells swell. Okay. So hypotonic is going to make a cell swell, basically. Fluid is going to leave the blood vessel and go into the cell, make stuff swell, hypotonic. Hypertonic is like hyper and fast. It's going to, because of the differences, it's going to pull fluid from the cells into the blood vessel, basically. So the cell is going to kind of shrink and shrivel. Where hypotonic makes cells and the tissues swell and go big, hypertonic is going to try to pull fluid into the blood vessels and it's going to pull it out of the cell and make the cells kind of shrivel up and that sort of stuff. That's a hypertonic solution. I hope that one makes sense. So, kind of going forward, some examples of some common IV fluids, isotonic, your normal 0.9% sodium chloride, or no, also known as normal saline. That is the same sodium chloride concentration that's found in the bloodstream. So it's kind of in the neutral ground. Isotonic. Lactated ringers is also isotonic. LR just has other chemicals in it, but it's just pretty consistent with normal saline. And D5W is dextrose 5% in water. That has a little bit of sugar in it, but it is still isotonic. Hypotonic would be less solutes, basically. That's why they get the hypo, less solutes than isotonic. And so hypotonic is half 0.45% normal saline or sodium chloride. So half normal saline. Again, the goal is to pull fluid out of the vasculature and into interstitial space. We'll talk about what those could treat. Hypertonic would be a higher hyper concentration of solutes, in this case, 3% sodium chloride. And again, a hypertonic solution is going to make the cells shrivel. It's going to pull fluid from the cells and give it back to the blood vessels. So some of the uses. So isotonic fluids can kind of depend. This is not all need to know, but just to give you kind of initial. So the gold standard is definitely the sodium chloride. Sodium chloride is for fluid resuscitation. Like we're gonna, prior to blood transfusions, we're gonna give them a bunch of fluid. They're dehydrated. We need to replace it. It always needs to be watched with patients that have heart failure or already have already have edema. It can cause fluid overload. All fluids in some way can cause fluid overload, just depends on where. Lactated ringers has more nutrients in it, more other electrolytes. So it has to be watched with patients that suffer from high levels of potassium. The liver has a hard time metabolizing lactate, but it's useful for more complicated cases of dehydration, burns, fluid loss in the GI tract, because that means that we're losing some of the nutrients there as well, that sort of stuff. And then D5W, again, can treat fluid loss and dehydration. It's more niche and more specific in its use cases. So hypotonic solutions, these are the guys that are less than the normal saline. So half normal saline, 0.5%, is a pretty classic. Again, this is a lower concentration of solutes than the blood plasma. So this causes the shift, right? Intracellular fluid. It's going to cause the cells to swell. So it's going to shift fluid into the cell and interstitial spaces out of the bloodstream. So this can be used with maintenance fluids. Usually it's used for diabetic ketoacidosis or to treat acidosis. It's treating acidosis by pulling, when the fluid pulls into the cells, it pulls the hydrogen out of the bloodstream and also into cells. So that's why you could use hypotonic solution like this. And this is something that has to be kind of avoided with faster rates or people that have low sodium levels, mainly because the sodium is going right. Less sodium means that sodium is kind of following the concentration. So they're going to lose more sodium into the cells and out of the bloodstream, because it's going to salt sucks. But this is goal of hypotonic is to pull fluid from the vasculature into the tissues and cells around it. Hypertonic fluids is another solution. So this is like high percentages of sodium chloride. So this would be like trying to replace a low blood sodium level. We could use this, but usually it's very critical use cases. This is very rare and can cause a lot of problems. So this does not happen that often that they will give hypertonic solutions, because basically what it's going to do is it could cause fluid overload in the vasculature, because it's going to pull fluid from the cells, shrivel the cells up. hypertonic and pull it into the bloodstream. So it could, especially if it's administered too fast, the biggest risk case for hypertonic solutions that would be a need to know is they can cause pulmonary edema if it pulls that fluid too fast, fluid overload in the lungs, which could lead to respiratory issues and even respiratory arrest. Um, and sometimes there is a high level of dextrose that is considered hypertonic, and this could be for like starvation and like very rare cases. I haven't seen a lot of these in my practice, but I didn't work in the ICU that often. I was a med surg nurse, but I have seen 3% sodium chloride before to treat mainly hyponatremia, low levels of salt. So these are more rare to use. So what we just learned, what is the effect of hypotonic fluids on our body? What is it going to do to our body? Hypotonic fluid. I'll give you a second to answer. Okay. And if you answered number two, you're correct. Hypotonic is going to make the cells become hippos. They're going to swell. So it's pulling fluid out of our vasculature or pushing it into interstitial space. Hypertonic is going to pull fluid into the vasculature, increase the. What type of fluid is 0.9% sodium chloride or normal saline? What's it classified as? Give you a second to answer. Okay. It is isotonic in the middle. So hypovolemia, it just means there's a low volume. Hypo means low and slow. So hypovolemia. Let me mark something out here real quick. So on this slide, you can kind of ignore this. I'll talk about that in a second. But overall, hypovolemia or fluid volume deficit, FVD, is another term for hypovolemia. Fluid volume deficit. This may be on its own. This may be because of other imbalances in the body, but this is I'm losing extracellular fluid. So basically, the loss of my fluid in ECF, mainly in the bloodstream, exceeds my intake ratio. There's your I's and O's, right? Losing more fluid than I take in. And typically, when that happens, I can lose electrolytes as well with these normal body fluids. So dehydration is not the same as fluid volume deficit, just to keep in mind. Dehydration is kind of its own thing, but what dehydration is basically saying is that the sodium concentration is higher compared to fluid. So this is losing water alone and sodium levels stay high. That's dehydration, and that's usually due to like the sweating and all the unknown losses of fluid without proper intake. So they are very similar, but dehydration is not necessarily just fluid volume deficit on its own. It's a little bit more multifactorial, where it's losing a lot of fluid on its own and maintain the salt level, and that's on the rise. That would be dehydration. But things with people with not enough volume, they're not really going to have a marked out hypertension, because the more likely someone with fluid volume deficit means they don't have enough volume in their bloodstream. They would have hypotension, low blood pressure, weight loss because of water weight. They're going to have tinted dry skin. So tinting, if you don't know, if you're checking someone's skin turgor, like on the back of your hand or around your collarbone, if I was fluid volume deficit or dehydrated in the same sense, if I were to pinch that skin, it would stay in place. That's tinting. Going to have increased respiratory rate. Pulse is going to be higher. Their heart rate's going to be higher as their heart tries to compensate for the missing fluid in the bloodstream. Oliguria is a low urine output, and they're just going to be generally tired, that sort of thing. So what's causing fluid volume deficit? Just general abnormal losses in fluid could be the culprit. If I'm vomiting a lot, excessive vomiting, diarrhea is losing a lot of fluid, excessive sweating, like heat stroke or being outside, and then nasogastric or stomach suctioning, losing a lot of fluid through my stomach, and overall just decreased intake, anorexia from not feeling well or some other condition causing it, not really taking a lot of food in, that sort of stuff. Or sometimes fluid shifting. So if fluid is shifting from extracellular, from the bloodstream into the cells or into interstitial space, severe edema, um, uh, fluid buildup in the peritoneum of the abdominal cavity, that's ascites with inflammation, and burns have a lot of effect because we regulate our fluid status a lot through our skin. So burns, depending on how bad they are, cause a lot of damage to sweat glands and our means of controlling that fluid balance through our skin, and that can cause a lot of fluid to shift to different places. Some other conditions: diabetes insipidus, which is also known as SIADH, the syndrome of inappropriate ADH. Diabetes insipidus means that ADH is not working effectively, and therefore we don't have antidiuretic. We go into a natural state of diuresis, losing a lot of fluid through our urine. Kidneys not working well, causing that third spacing, or obviously bleeding. If I'm bleeding, I'm losing a lot of fluid from my bloodstream, which put me in a fluid volume deficit. So what am I going to do as a nurse? Well, with most fluid things, intake and output in an ICU critical setting could be even hourly, but at least every 8 hours. Very maintenance. They do daily weights to check because fluid status can really shift weight. Vital signs, changes in blood pressure, changes in heart rate, skin turgor assessments. Um, Try to prevent fluid loss, making sure they're drinking, eating, IV fluid replacement with isotonic fluids, likely, that sort of stuff. So we'll talk about this case study more in class, but just to give you kind of an idea, 93-year-old female, patient admitted to medical surgical floor with Klebsiella pneumonia. Klebsiella is a type of bacteria usually found in our stool. Urinary tract infection is sepsis. So they've got infection all over the place. They've started IV antibiotics, which makes sense. So second day of patient being admitted, the UAP, which is, nurse tech, that sort of thing, reports to the nurse that the client's urine output for the past 24 hours has been 350 milliliters. What is the nurse's priority action? Now, that does not sound like enough, does it? So that's an issue. So thinking nursing wise, what's your priority action? Okay. So correct answer. If you answered D, that is the correct answer. So before contacting a provider is the right thing to do, but okay, let's think about this, right? Before contacting a provider, what do you need to know? What else is wrong with this person, right? So what's their current situation, the reason they came in, so their admitting diagnosis, what brought them here, and then what's their past medical history? We know they have an infection, that's what brought them here. What else is going on, right? What other things do they have a history of? Do they have a history of bladder or kidney trouble? What else is going on? So their intake 3,400. So if you kind of do that intake output math, so their intake's 3,400, they've only had 360 out. They're, positive over 3 liters of fluid. It's got to be going somewhere. So you would check their bladder, bladder on palpations not distended, which is a good thing. Urine is tea colored. Well, that makes sense. Why? Urinary tract infection, and so cause smelly urine, discolored urine. Lung sounds, coarse crackles. Well, what do you think there? Could be fluid overload. Also, could be their severe pneumonia. And they have edema, 2+. So that's 2+ pitting edema. fluid volume overload. They have too much fluid volume. And what do you want? What are your thoughts? So you think about this one for a minute, but we could definitely bladder scan this person to see if they're retaining their urine, they're making the urine, their kidneys are functioning okay, but they're not voiding for some reason, they're not urinating. So is it retaining in their bladder? Um, this person is kind of exhibiting symptoms of probably a possible fluid volume overload, which we're about to talk about. So, trying to give you an idea of what to look ahead of here. But what does that mean? So, they still may need, again, we need to check for urinary obstruction, kind of rule that out first, but they still may need some fluid replacement because, for one reason, we want the fluid to shift and we want them to stay hydrated. We want to cut them off completely. But kind of fluid could we do to maybe pull some of this edema from interstitial space? I'll give you a second. Think about it. Pause the video if you need to. That's right. Hypertonic solution. Hyper is going to pull fluid from the cells and interstitial space back into the vasculature, which means it'll get to the kidneys if we're not producing urine, hopefully produce some. So a slow rate of hypertonic solution could be a solution for her. I'm not saying it's 100% is, but this is fluid volume overload. So let's talk about it. So fluid volume overload or fluid volume excess, FVE, or again, other names for it, hypervolemia. So for whatever reason, just incorrect homeostatic mechanisms are causing this: heart failure, kidney injury, uh, cirrhosis of the liver can really do it. Heart failure, kidney injury, definitely going to be the a big culprit in fluid volume overload. And what contributes to this? High levels of table salt or other high sodium foods can lead to this because salt sucks. The more sodium I have, the more salt's going to get pulled in different places, or excessive sodium and administering sodium containing fluid. So, what's this person look like? Basically, too much fluid and with failure to eliminate. So, they could have level of consciousness changes, confusion. They could have pulmonary congestion, that's pulmonary edema, and that could be the coarse crackles. They're going to have a really strong pulse, what you call bounding pulse. You know, you can almost see it. Blood pressure up. Their jugular veins are going to be distended and almost palpable. Um, Tachycardia, higher heart rate to try and compensate and keep moving fluid. And they're going to probably be nauseous, that sort of stuff. So, again, kind of working through it, signs and symptoms. They're going to have edema, the stenotic brain, neck veins, crackles in their lungs, BU and creatinine are going to kind of be off in some form or fashion, mainly showing kidney function. And table 10.4 has signs and symptoms. But this also summarizes them pretty well. Sounds wet. They're confused. They have edema, heart rate, blood pressure issues. So, what can we do? We got to measure their intake and output with any fluid volume issues. This time we would restrict fluids. We would take weights to kind of keep up with that stuff. Just most of these patients are going to have careful observation and assessment. So, what are some common signs of hypervolemia or fluid volume excess or overload? So many names. And if you guessed number 4, you'd be right on. That would be definitely more in line with that. The other options: weight loss, dehydration, dry skin. These are all options in the family of hypovolemia, meaning there's more fluid that is shifted to other places, but it's not in the blood vessels. So medical management, you could do diuretics, dialysis in severe cases. You need to restrict sodium, maybe have to fluid restrict. Daily rates, again, this is kind of just summarizing daily weights, monitor responses to medication, fluid restrictions, salt restrictions, and then checking medications to see any interactions, those sort of things. Okay, so moving on past the fluid now to electrolyte imbalances. Um, okay, electrolyte imbalances. We'll move into that. So there's several electrolytes. Some of the main ones to kind of think about though is sodium, potassium, calcium, and magnesium. Phosphorus as a sidebar because calcium and phosphorus have an inverse relationship, and then so does sodium and potassium tend to have an inverse relationship. But mainly focus on sodium, potassium, calcium, and magnesium. Chloride is also an electrolyte, but typically there's not too many imbalances of that. But of course, these are blood levels because that's what we can measure, right? So sodium normal level is 135 to 145 milliequivalents per liter, usually in milliequivalents. So remember that salt sucks. So water likes to follow salt. This is the most abundant electrolyte in the ECF, extracellular fluid, regulated by our thirst, aldosterone, the renin system, important for muscle contraction and nervous system impulses. So if I'm hyponatremic, so that means I'm again hypo is low, nat is Na is sodium, and emia is always about blood. So this is saying low sodium in blood. Hyponatremia is be serum sodium less than 135 milliequivalents. For acute, this could be fluid overload. Fluid build up in the blood vessels is going to kind of dilute it down, and that would be hyponatremia. But also some of the other causes, renal disease, diuretics, kind of losing excess amount of um, uh, fluid and sodium in urine. Gastric suctioning, vomiting can lead to it. Diarrhea, any of these fluid losses. Another one that's not talked about in this slide is SIADH, the syndrome of inappropriate ADH. Again, large amounts of fluid get lost through the kidneys, and that would be excess water compared to sodium, and we're losing sodium. So another kind of acronym is SALT loss, which is kind of the symptoms. General signs and symptoms: confusion, could be even as severe as seizures and coma, but general lethargy like tired, confusion, headache. SALT loss is an acronym that's used some places. So SALT loss is S for stupor or coma, which would be the lethargy, not really responding very well. The A in the SALT loss is anorexia, not hungry. L would be lethargy. T for salt loss is tendon reflexes are decreased because of their nervous system and musculoskeletal effect of sodium. L for salt loss is limp muscles weakness. O is orthostatic hypotension. So typically they're going to have some blood pressure decline, especially with position changes. The first S is seizures, headaches, and then stomach cramping is the last S. More common in women with a small stature, extreme temperatures, excessive fluid intake can kind of dilute the blood, the ECF down to where there's not as much sodium compared to water. That's more rare. But exercise kind of abuse can be a cause of hyponatremia. So what is a nurse going to do? Definitely with this and fluid balance, intake outputs, urine specific gravity. You're seeing if they're in fluid volume overload. Again, that would be like fluid volume overload is causing basically a dilution. It's diluting down the amount of sodium compared to water in the blood vessels. And there would be likely more fluid in the ICF in interstitial spaces or inside the cells, and then daily weights for kind of monitoring that, and replacing sodium would be the ideal treatment for that. Again, we could do a hypertonic solution, but we to try and pull fluid from spaces into the vasculature, but that could also be risky too. So it's hyponatremia, takes a little bit more specific treatments. So on the other end of the spectrum of the balance, more hypernatremia, usually fluid loss or fluid volume deficit, too much sodium intake, heat stroke, dehydration, those kind of things. Overuse of hypertonic IV solutions. So this person can be really thirsty, actually messes with their temperature. They can have a low grade fever, really high serum osmolarity, because again, that measures kind of the concentration of salt in our bloodstream. So serum osmolarity be high, and then urine to specific gravity would also be high. So think dehydration, heat stroke, those kind of things. Fried salt's a funny little acronym to kind of remember it. Flush skin, fever, low grade, restless, irritable, anxious, maybe confused, but much more like not stupor or coma with the hyponatremia, but more restless confusion and heightened sense of awareness with hypernatremia, more excitable nervous system impulses, that sort of stuff. Increased blood pressure, fluid retention. E would be edema, decreased urine output, dry mouth, skin flush, agitation, low grade fever, thirst. So much more of a flushed, irritable, low grade fever, increased blood pressure, and then high serum osmolality and specific gravity. Treatment, very similar. Do an intake output. Urine specific gravity measurements, changes in neurostatus, monitoring daily weights, monitoring skin turgor, trying to get urine specific gravity back level, heart rate, respiratory rate always, and then their neurological status would be like an end for both hyper and hyponatremia. Neurological status changes could be kind of like signs that are towards the end of the process. So on all that, what's the normal range for serum sodium levels or blood sodium levels? Give you a second to answer. That's correct. It is number 4. If you pick number 4, you're correct. What's a common cause of hypernatremia? Give you a second to answer. That's correct. It is fluid deprivation, dehydration, heat stroke, not enough fluid. So, moving on, talk about potassium. So, sodium was the most common electrolyte we find in extracellular fluid, so in our bloodstream compartments. Potassium is the most common electrolyte we find in our intracellular fluid. So, potassium is hugely important for skeletal muscle contractions. Specifically, cardiac muscle really relies on potassium. Most of our potassium is found in our cardiac muscle to help with electrical impulses that fire through our heart to contract it. Very important for high levels of sodium or to be in the cell. So that's why the blood level is a kind of a lower number than sodium, because it's mostly found inside the cell. That's where potassium should be. So when we take a blood sample, it makes sense that it's a lower number than sodium. It's 3.5 to 5. Again, can change on the book and what hospital you work at and those sort of thing, but that's the general consensus. 3.5 to 5 milliequivalents is a normal potassium. This is a very life-threatening condition. If potassium is too high or too low, because of its super importance for cardiac impulses, electrical activity, and the functionality of the cardiac muscle, the big risk with potassium imbalance is either high or low is going to have a risk of causing cardiac arrhythmias. So cardiac arrhythmias, we'll talk more about that. But the goal of the sodium potassium pumps we have in our cell membranes is to kind of keep the sodium on the outside and keep a concentration of potassium on the inside somewhat like it is. So potassium levels can kind of get out of whack, especially with renal failure patients tend to have high potassium levels, acid base imbalances, or sometimes cellular damage, burns, surgery, accidents, physical tissue damage can have a lot of big effect on potassium levels. Potassium can kind of cause uh, again ECG changes, so changes in a rhythm, dysrhythmias or heart arrhythmias, and diarrhea and nausea can kind of secondarily. But your big ding 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 nursing thought, if I hear about out of whack potassium, I'm thinking about cardiac arrhythmias and heart issues. Foods that are rich in potassium: spinach, salmon, beets, white beans, bananas, avocados, white mushrooms. So hypokalemia is, again, hypo is low and slow. So this is too little potassium, less than 3.5 milliequivalents. So signs and symptoms of hypokalemia. Uh, a sick Walt is a little goofy acronym, but alkalosis, shallow respirations, irritability, confusion, weakness, arrhythmias, lethargy, thready pulse. So thready pulse basically kind of means like a weak pulse, necessarily a high or low, just a weak pulse. Um, and so it's showing you that in hypokalemia, you can have some ST depression in a QRS complex, or in the ECG, you're going to see some really odd waveform, like a shallow T wave and ST depression, and a really prominent U wave on the tail end of your ECG complex. So again, the biggest take home from potassium is going to be the cardiac issues. Another slide about hypokalemia, again, less than 3.5. So causes, again, this is a nice chart that summarizes from registernursern.com. This is pretty good. So what is happening is your body is getting rid of potassium. Why is that? Well, drugs could cause it. Diuretics such as loop diuretics, furosemide, which some of you know as Lasix, laxatives can get rid of it in our stool. Not enough consumption of potassium, don't eat a lot of foods with potassium. Too much water kind of causes fluid shifts. And then losing fluid, diarrhea, vomiting, those kind of things. So think of hypokalemia as I'm losing fluid and it causes a lot of shifting. So they're going to be hypo, they're going to be low and slow, lethargic, shallow respirations, lethal cardiac dysrhythmias, that sort of stuff, limp muscles, leg cramps. The potassium is important. Potassium sodium pumps go back and forth. It is pretty important for muscle contractions, and especially in skeletal muscles, but of course, especially in our cardiac muscle. That's what you got to think of. But leg cramps, muscle cramps, and then cardiac arrhythmias. How do we treat it? Well, we're going to replace it. You can do oral depending on the patient's, swallowing status, that sort of thing. IV replacement is a possibility with potassium, but there's some things to think about with that. The rate has to be kind of slow. It's going to burn at the IV site, but we can do food. We can do replace potassium with just pure replace it with tablets. Replacing potassium can be very dangerous in end-stage renal disease patients. So patients that are on dialysis or right there at it have a hard time. Dialysis is the only way their kidneys filter stuff, and so they tend to suffer from elevated potassium all the time. So if we have to replace their potassium, it has to be done very carefully, and the nephrologist will think through that. So on the other end of the spectrum, you have hyperkalemia. Again, hyper is high and too much. Acidosis can lead to this, basically because the hydrogen ions are moving into the cells, causing potassium to move out. And that's kind of the opposite with hypokalemia. It could be an alkalosis, kind of bicarb taking the place, and hydrogen staying in the blood vessel and causing potassium to leave the cell, or to go into cells more, Acidosis is going to cause potassium to leave the cell and end up in the bloodstream because hydrogens are taking the place of that acid component in the cells. And so it's going to cause, again, some EKG changes, a really, really tall peak T wave. Not so much ST depression, but not necessarily a need to know. Again, potassium low or high, it's still going to cause irritability and kind of muscle cramp, or it's going to cause muscle excitability and muscle cramps and twitches, ECG changes, very abnormal cramping and muscle contraction effects. So the summary of it, really, here's another chart that's good for hyperkalemia. Again, causes the body cared too much about potassium. So potassium moved from inside the cell where it's supposed to be to outside the cell. So burns, tissue damage. Think of the cell destruction causing potassium to leak out into the bloodstream. Adrenal insufficiency, Addison's disease, but renal failure and issues with the kidneys. Too much potassium intake, that's rare. And then drugs, blood pressure medicine, ACE inhibitors can affect potassium level, but also there's other diuretics that spare potassium, which is good because we don't want to lose it, but they can have the tendency to have the opposite effect sometimes. And then the signs and symptoms is an acronym murder, which is funny but also terrible. But muscle weakness, urine output very little. So anyone renal failure is at risk for hyperkalemia. Could have respiratory issues because of the muscles or weakness. Decreased cardiac contractility. Again, big take homes from high or low potassium is always going to be these rhythm changes with the heart, or muscle contraction is going to be an issue either way. So what do we do about a hyperkalemia, a high potassium? One of the most common medications we give by mouth is called Kexolate. Kexolate is a gross medicine, but really what it's trying to do is get rid of potassium. Well, how's it going to do that? It's going to pull it from places into the GI tract and get rid of it through stool. So basically, Kexolate causes some diarrhea to try and get rid of potassium. Basically to kind of balance out. Sodium and potassium have a little bit of an inverse relationship, not entirely, but we're going to retain some sodium and let go of some potassium. We want them to have stool to get rid of. So Kexolate acts as a laxative in a sense of pushing stool out that pushes potassium out with it. And some other fixes that are, if someone can't swallow, or this is more an emergency situation, very, very high levels of potassium, like above 6.5. There are a bunch of other treatments. Dialysis is one of them. The most common I've really seen is probably IV calcium, because calcium, we're about to talk about, tends to be another electrolyte that you find more commonly inside the cell. And so if we replace calcium will make its way into the cell and bring the potassium back into the cell with it and get it out of the bloodstream. But what I've usually seen a lot of in emergency situations is actually number two, is the insulin glucose combination. So what insulin does, insulin has, if you want, here's kind of the AK nuts to know, maybe nice to know. This is a little bit nuts to know, but I'll give you an explanation of why insulin works to treat hyperkalemia. So what insulin does is insulin is a hormone that tries to cause, right, to basically go all your cells and tell them to take in glucose. Well, in this case, insulin is going to, when you give it to someone with a hyperkalemia, it's going to go to all the cells. The cells all pretty much have receptors for insulin. And when that insulin binds those receptors on the cell, it causes increased activity of the sodium potassium pumps and this enzyme on the outside of the cell. And this basically just kind of ignites the sodium potassium pumps to work overload to keep potassium levels in the cell higher than they are outside the cell. And so therefore, boom, starts pulling potassium back into cells. And the reason you also give glucose with this is because, especially not even if they're diabetic or not, but especially if they're not diabetic, you don't want to give someone insulin. Insulin is going to cause, the blood sugar to drop on someone, diabetic or not. And so we give the insulin with some glucose because we want to keep their blood sugar from dropping. So we're going to give them some glucose and give them the insulin to try to make the potassium pumps kick on and shift potassium back into the cells from blood plasma. So again, there's some other options here. It just kind of depends. But that's kind of the most common ones I've seen. So another electrolyte, calcium, mostly found in our bones. Our bones are mostly calcium and some phosphorus. Super important muscle contractions, nerve impulse. It has a role to play in helping us blood clot, a lot of stuff. Mostly, this is an intracellular fluid electrolyte inside the cell. And that's why, again, number for the normal range of calcium you to get in a blood test is lower than say sodium or something like that. So 8.6 to 10.2 milliequivalents per deciliter. So calcium is mostly found in the cell and really important for muscle contraction and nervous system impulse. So signs and symptoms of hypocalcemia, so a little bit too low, CATs, convulsions, arrhythmias because of its role it plays in muscle contraction, even cardiac muscle, tetany, stridor, and spasms. So if someone's hypocalcemic, it basically look at it like a balance. They don't have enough calcium in their bloodstream, which means they probably have more calcium in the cells, especially the muscle cells. So everything muscle wise is going to be excessive, excitable. Hypocalcemia equals more calcium in these muscle cells. So more contractions, convulsions, spasms, cramping, those kind of things. Numbness and tingling and contractions in distal parts, fingers and toes. Tetany, if you don't know what tetany is a basically a form of where the wrist and tendons and muscles in the wrist lock up and kind of spasm the whole hand and wrist. That would be tetany. Some signs that show it, Trousseau sign, is where I put a blood pressure cuff on someone's hand and tighten it, and their hand and wrist and arms start to twitch really effectively. And then Chevet's sign is if I go and tap someone's cheek and they start to twitch, that's response to the muscles and the facial nerve. And typically they'll have a little bit of a decreased blood pressure with this, but think overstimulation of muscles and nerves is hypocalcemia because there's too much calcium in the cells. There's supposed to be a better balance. How do we treat it? Well, Tums actually can help fix it. Tums is sodium bicarbonate. There's other medications, calcium gluconate, calcium chloride. IV calcium has a potential to cause cardiac effects, and it affects the muscle too fast. So a lot of times it's treated orally or has to be monitored very closely with IV replacement. So on the other end of the spectrum, hypercalcemia. So what's going to be involved here? So, well, think the opposite of hypo. If I have hypocalcemia, it means there's more calcium kind of in the cells, more muscle and nervous system excitability. If I have hypercalcemia, it's like the balance is out of whack. There's more calcium inside the bloodstream, ECF, than there is in the ICF. And this kind of throws everything out of whack. So the opposite of this would be hypocalcemia with hyper is weak muscles, decreased reflexes, decreased muscle contractions, flaccid weakness in the muscles. So everything kind of slows down. Constipation, maybe gallstones because the gallbladder, everything kind of slows way down. So generalized fatigue, decreased responsiveness from the nervous system, kidney stones, gallstones, those sort of things. Could be caused by a few things. What they're showing here in this picture is a common cause could be what they call hyperparathyroidism, or a parathyroid adenoma, a tumor that's secreting PTH, parathyroid hormone. If you kind of remember hormones, parathyroid hormone job is to raise blood calcium levels to help us regulate our calcium because we need plenty of calcium all the time for muscle contractions. So we like to keep a solid level of it, and PTH is always trying to retain calcium in the kidneys. But if we have too much PTH, it means it's going to retain too much calcium, and therefore it raises in the bloodstream and causes all kinds of weird out of whack things. So Some of the treatments for too much calcium, hypercalcemia, is trying to dilute our blood back down. So fluid replacement to try to dilute that and promote calcium going back into cells. IV phosphate, so phosphorus is one of the electrolytes that kind of acts as a inverse relationship with calcium. Lasix, try to get rid of some fluid and get calcium to go back in the cells. And then calcitonin is a hormone secreted by our thyroid gland that tries to regulate calcium by bringing it down. So we might get to do some calcitonin replacement. Magnesium, also another one that tends to be in mostly in ICF cell or intracellular fluid. Excuse me. Magnesium normal level 1.3 to 2.3 3 milliequivalents per deciliter. Magnesium mostly involved and helpful in muscle contractions as well. What could cause low magnesium level? Similar to low potassium and other stuff, but or high potassium and other things is diabetes, ketoacidosis, DK, and acidosis, issues with diarrhea or malabsorption. We get a lot of our magnesium from food and those kind of things. So if I have issues with GI, that's where magnesium levels could drop. Alcohol abuse, because of the way alcohol is processed by the liver, kind of takes up some of our magnesium levels. So common stuff with magnesium level issues that are low is loss in the GI system and alcohol abuse. And so magnesium, again, kind of thinks similar to potassium levels as far as weird heart rate issues. So if I have, it's very similar to potassium in the sense of cardiac arrhythmias, arrest, but it's similar to the thought process of almost, again, kind of like calcium, where if I have too little calcium, my everything means there's more in the cells and it's higher everything is kind of similar. So hypomagnesium means there's more magnesium comparatively inside the cell than there kind of should be, and this is going to cause weird reflexes and cramps and tremors and elevated heart rate and irregular arrhythmias and muscle cramps. So hypermagnesium, magnesium, excuse me, is too much magnesium. So low everything, similar to a hypercalcemia. Like I'm gonna have decreased blood pressure, decreased heart rate, reflexes are down, sweating, just general muscle and skeletal muscle weakness, those sort of things. It's usually rare, but if it comes from it, it's going to probably come from kidney function being impaired, that sort of stuff. So, on to kind of the final section of all this, acid base imbalances. So, what is acid? What is base? So, the basics is that our blood plasma has a pH value. pH represents basically as a measurement of hydrogen ions in a given solution, in this case, our blood. So the hydrogen ion concentration, this measures basically how acidic something is or how alkaline or alkalinity of the blood. So how acidic it is or how alkaline it is. A normal blood plasma pH for us is 7.35 to 7.45. That's in the middle ground. To give you a comparison, like stomach acid falls into like a pH level of like 1 or 2, I think. And then alkaline, we'll be talking about all the way to the extreme of like batteries and batteries are a little bit acidic, excuse me, bleach and some other stuff way on the other end of the spectrum. So anything outside of this normal pH range basically is corrosive or damaging to us as tissues. So we have some systems that buffer things. Our kidneys are really good at buffering, but they're probably the slowest to respond. They take a lot of time. Our lungs are pretty quick at responding. CO2 loves hydrogen. CO2 and hydrogen love each other. And so CO2 will bind with hydrogen. And when we breathe out, we breathe out CO2 and hydrogen with it so we can regulate our pH level. And then we have chemical buffers that react all the time. Bicarb is the base. So bicarb base, hydrogen acid. That's going to be kind of the balance here. So acid base balance, how do we maintain it? Basically, again, if we have too many hydrogen ions, I'm more acidic. The body works in a really narrow range. Okay. So um, the first buffer system is basically Buffy buffer that they've talked about here. This is bicarb binding with hydrogen to mask it and then get rid of it later. And that kind of controls our acidity. And so if the buffer system can't handle it, respiratory kicks in. CO2 loves to combine with hydrogen to make carbonic acid. We breathe it out. And then last, the most strong and dependable of our buffer systems, the kidneys, they control bicarb levels, and they can get rid of acids, they can get rid of bicarb, and they can balance our acidity that way. And so this is a normal pH of body fluids is on the bottom of this picture, but you can see that our gastric juices are real low. Urine is pretty high acidity. So again, just kind of noting to understand, it seems more complicated than it needs to be, but that's kind of how all medicine stuff works, is this guy here, right? So if hydrogen ion levels concentration is increasing, then my pH on the scale is going to go down, more acidic. If I have less hydrogen ions, the pH scale becomes more alkaline, so the number would go up. So just for example, like 7.5, 7.3, just to give you an example. So what does this mean for nurses or in the medical field? What do we do about acid base balance? How do we tell what's going on? The big thing to reading acid base balance is what we call an ABG. An ABG is an arterial blood gas, and you may have heard of these before. This is taking a venipuncture or arterial puncture, excuse me, of the artery, usually the radial artery in the wrist because it's smaller and it's able to heal pretty well after some pressure dressing for a few minutes. But it take arterial blood, and then we do an ABG on it and we figure out these values. Now we have to do arterial blood because arterial blood will have appropriate oxygenation level. A venous puncture will not have appropriate oxygenation levels and doesn't give us the most accurate, because it's already went through the capillary exchange, already went through tissues. Venous blood doesn't give us the most accurate ABG. And so I always used to hate if someone ordered a venous ABG because I've always felt like it was not as accurate as an ABG. But a lot of your respiratory therapists in hospitals do the ABGs most of the time. So ABGs, what are we looking for here? So normal parameters, pH, again, we mentioned that 7.35 to 7.45. Normal CO2 levels in an ABG should be between 35 and 45 millimeters of mercury. And then normal levels of bicarb, 22 to 26 milliequivalents per liter. We want our partial pressure, is what these are, of oxygen to be above 80%. That's different than the bottom number. SaO2 is like pulse ox. When you put a pulse ox on someone's finger, that's what you're looking at SaO2 is. So above 94%. And so basically, with ABGs and understanding acid base balance, for the most part, it's pretty much going to be eyeballing what the pH is, and then looking at these two guys and what kind of relationship they have will help us determine kind of what's going on with an acid base imbalance. So let's look at some of these. So respiratory acidosis. So acidosis means pH is lower, below 7.35. And it means that our usually typically um our uh our pressure, partial pressure of CO2 is elevated. So this is above 48, I think, but it would be 40, it'd be 45 basically. So anything above 45 millimeters of mercury on the CO2 and a lower pH on the scale is telling us acid. This is telling us that it's respiratory related. When we look at it and the CO2 is out of whack, that's telling us it's respiratory related. So things that mess with this, hyperkalemia, they're going to have a low ventilation, hypoventilation, and lacking oxygen is very likely. So shallow breaths, could be disoriented, drowsy, that sort of thing. Um, so what's causing this? Just general respiratory depression from oversedation with medicines. So overdose, other neurological symptoms causing respiratory depression, um, airway being blocked, COPD patient is much at risk for respiratory acidosis, and so COPD, pneumonia, blood clot in the lung, pulmonary embolisms, acute respiratory distress syndrome. That's the ARDS. So a lot of breathing issues. So basically, with understanding acid-base imbalances, they come into four categories that they're talking about here. And they're either going to be respiratory or metabolic. And then they can either be respiratory acidosis or respiratory alkalosis or metabolic acidosis, metabolic alkalosis. They can only be one of those four, really. So basically, you can always, if it's talking about lungs and I'm looking at an ABG that has fluctuations in O2 or CO2 levels, I can know that this is a respiratory issue. Then I just have to determine after that if it's acidosis or alkalosis. If some of the CO2 and the O2 levels look pretty standard, but we have a pH imbalance, it's probably metabolic. So if it's not talking about the lungs, you can probably guess it's not a respiratory type of acid base imbalance. So respiratory alkalosis, this is going to be, again, on the opposite end of the spectrum, elevated pH greater than 7.45. PCO2 is probably going to be low, and bicarb could be up, but you'll see PCO2 is low. And we do want an appropriate amount of carbon dioxide. We think carbon dioxide, oh, bad, but we want carbon dioxide. So respiratory alkalosis is more rare, but this is like hyperventilation, really increased rate, high heart rate, hyper reflexes, anxiety, irritability. So what's causing this? Hyperventilation during anxiety attacks, and fear, basically. Anxiety attacks, fear could lead to respiratory alkalosis. So if you, example would be, have you ever seen, maybe you haven't, they don't make, but old school movies, I'm thinking of like the original kind of, I think it was in the original It, with Tim Curry, but just movies that have like a character or a kid that deals with anxiety and uses like an inhaler and stuff. He starts freaking out and hyperventilating. They'll give them a brown paper bag to breathe into. Why? Why are they doing that? Well, the reason they're doing that is you're hyperventilating, you're blowing off all the CO2, and CO2 levels are something we need to keep regulated. We have just as much problem losing CO2 as we do gaining too much of it. And so we lose it. It messes with our, again, acid base balance. And if I breathe into a brown paper bag, I'm going to breathe back in CO2 and thus raise the CO2 level and kind of correct my acid base imbalance. And that's why they would do that. That's never explained in any of those movies, of course, but that's what hyperventilating, someone's freaking out here, breathe into this brown paper bag. And I always used to wonder when I was a kid if I ever saw that somewhere. I'm like, why would we do that? How does that make someone breathe better? But this is why you blow out the CO2 and breathe it right back in and bring your CO2 up. So on the other end of the side, metabolic, again, can be one of the four, but it's only going to be respiratory or metabolic, is a low pH on the scale. So acidosis, metabolic acidosis, a low pH, and a bicarb that's going to be low. So a bicarb that's going to be low is what you're looking at. So less than 22, and usually a low, because basically there's just not enough bicarb is what we're saying here with this. So metabolic acidosis, low pH, low bicarb. Basically, I think some of the issues just kind of know where it comes from. These are some of the symptoms. They're going to have vasodilation, muscle twitching, nausea, vomiting, what they call Kussmaul respirations, very abnormal respiratory pattern. But what's causing this? So, diabetic ketoacidosis is a metabolic. The acidosis, again, hydrogen ions shift because they're so excess, they shift into cell, mess up potassium, create hyperkalemic situations. Um, Too much hydrogen elimination, or sorry, decrease hydrogen elimination in renal failure. So you see a lot of acidosis with renal failure patients because they can't get rid of potassium. There's the hyperkalemia, right? They can't get rid of the hydrogen like they should. There's the acidosis. So bicarb production is delayed, um, or we get rid of bicarb by overuse of laxatives, diarrhea, or other elimination issues, chronic diarrhea, or something like C. diff causing a bunch of diarrhea. We can lose bicarb. We get a lot of our bicarb manufactured from the food we eat. And so you think losing stuff stool wise, I'm going to have a drop in bicarb, and that could lead to metabolic acidosis, especially in like a perfect storm of a renal failure patient that has C. diff that gets diarrhea. There's your metabolic acidosis. So metabolic alkalosis, again, metabolic because it's not dealing with the lungs. We got a high pH and we've got a high bicarb typically. So some confusion. Again, potassium might drop in this scenario, so we can have some kind of rhythm issues, uh, nausea, vomiting. They're gonna be anxious and have seizures typically, or not typically, but there'll be anxious seizures possibility. Typically anxious. What would cause metabolic alkalosis? Much more rare, very rare, but bicarb levels are high. Antacids, too many antacids. I'll actually talk about this in a second. Too many antacids because antacids, Tums, are sodium bicarb because they're trying to reduce the acidity of the stomach to treat indigestion and GERD and burning of the esophagus. And then we do NG suctioning. We suction too much stuff out of the GI tract of the stomach. We suction too much vomiting. And this takes away a lot of acid. And so then the bicarb kind of wins. So you have to look at this kind of like a teeter totter a bit, kind of like this, where you kind of think of hydrogen and bicarb want to have this specific relationship, right? And they want to stay in balance. Now, there's usually more hydrogen than there's bicarb, the number's higher, but basically they're kind of in balance. So if you say, if I had the only time I've really ever seen metabolic alkalosis in my practice was a woman that was over abusing Tums to treat her GERD like crazy. And she actually put herself into a metabolic alkalosis state, which is the only time I saw it. But let's just use that example, right? If I say I had too many Tums, that's going to increase bicarb level. Now, right, this shifts the scale where bicarb is winning. So that would basically more bicarb compared to hydrogen, pH would start climbing. Now we are metabolic alkalosis, but let's say the opposite. Let's go somewhere different with that, right? So if we said, again, on the respiratory side, let's see, I'm a COPD patient. Hydrogen loves CO2, and I'm retaining too much CO2. So hydrogen goes up. Now it's winning the battle against bicarb. Hydrogen level goes up. pH on the scale goes down. I'm acidic. And because it's related to the respiratory system, it's respiratory acidosis. Again, comparatively, bicarb necessarily move, but it's just compared to the other two. They want to be on an equal playing field of their numbers. I hope that makes sense. We'll talk more. We can talk more about it. So, how do I interpret an ABG? This is kind of where we'll finish this chapter off. I have to identify the pH. I'm going to look at the partial pressure of CO2, and then I'm going to look at the bicarb level. I need to identify if this is respiratory or metabolic. What's driving the pH change? And then identify if there's compensation. So what compensation is basically saying is that the body will try to homeostasis, will try to compensate for levels that are out of whack. So say, I've got issues, the kidneys are in alkalosis, they're going to try to get rid of bicarb and reduce how much hydrogen's excreted. If I'm in acidosis, I'm going to increase how come bicarb is formed. So I'm going to try to neutralize acids. I'm going to get rid of acids. And alkalosis for the lungs, they're going to slow their breathing down. Or that's the goal. Try to slow your breathing down to raise CO2, thus raising carbonic acid. In acidosis, I'm going to breathe harder, deeper, and faster to lower my CO2 and then lower the carbonic acid level. So compensation is basically uncompensated. pH is completely not normal. The driver is abnormal while the other is normal. It's not helping. So pH 7.15, CO2 is high, bicarb is normal. And so the driver of this is CO2. And so this is a respiratory uncompensated respiratory acidosis. Partially compensated is saying the pH is not normal. Driver's abnormal, compensator's abnormal. So everything's abnormal. Try to help, but only helping partially. So 7.28, we're acidotic. CO2 is abnormal, and bicarb is also slightly elevated. So this is the body is trying to compensate by increasing the bicarb, but they're not there yet. Fully compensated, pH is normal. Both others are abnormal. One's the driver, the other is the compensator, and it's worked completely. So what it's saying is that pH has now risen back to normal. CO2 is still slightly high. Bicarb is high as well. It's abnormal, but it's balancing out the hydrogen and the CO2, and they are getting us back to normal. So how to interpret ABG is acid base. This mnemonic is Rome, ROME. So Rome is respiratory opposite. So basically, if it's respiratory related, my pH is going to be up while the CO2 is down. That's alkalosis. If my pH is going down and CO2 are opposite up, it's acidosis. For the metabolic side, typically you're going to have an elevated pH with elevated bicarb. They're equal. Metabolics equal. And if I have a pH that's decreasing, I'm going to have a bicarb that's decreasing. And so kind of this is looking at it as well. Another way to kind of look at it. This is a video that does a really good job of kind of explaining everything. So we'll watch this quick one here.
We made a free ABG study guide and practice questions. So once you're done watching this video, head on over to simplenursing.com and download your free cheat sheets, and I'll include the link in the description below, right below this video. Okay, let's get into it. We're going to be covering the basic overview in this part 1, including pathophysiology and memory tricks. And then we're going to break down some practice questions toward the end of this video, including the really tricky fully compensated versus partially compensated ABGs. So be sure to stick around. So what are acid-base imbalances? Well, it's just the balance of acid and base of the body, kind of like a tug-of-war. The body loves to keep these in balance, measured in blood via the pH. So normal pH is 7.35 to 7.45. Too low, under 7.35, we become acid. Basically, the body goes into acidosis. And too high, over 7.45, we become more base. The body goes into alkalosis. Now, that sounds pretty simple, right? Well, here's where it gets confusing. The key players that keep us in balance is HCO3, known as bicarb. This is our base. That helps to put the body in this alkalosis. So the memory trick, think of the double B's. Base equals bicarb. And CO2, our carbon dioxide, is our acid, pushing the body into an acidotic state. So too much CO2, we get a body that is in acidosis. So the memory trick we use, just think carbon dioxide is carbon diacid, since too much carbon dioxide pushes us into acidosis. Lastly, hydrogen ions are a form of acid, found in the stomach acids as well as urine. So the memory trick, just think hydrogen ions is high acid. Too much hydrogen ions equals an acidotic state. Now, simply organize this in your mind. What makes the body acidotic? Well, hydrogen ions get high acid, and carbon dioxide, just think carbon diacid. And for base, which makes us alkalotic, just think bicarb base. Check out our brand new app and get access to our new pharmacology and med-surg mastery courses, plus 11 other courses like fundamentals, pediatrics, maternity, mental health, and more, complete with over 300 follow-along cheat sheets and a massive quiz bank loaded with detailed rationales to test your knowledge. Join for free. Click the link in our description below. Now, the main organs that control these are the lungs and the kidneys. So the lungs control carbon dioxide, that CO2. We breathe in oxygen and breathe out that CO2. Normal gas exchange, right? So just like you heard, the main way to get CO2 out of the body is by exhaling. So the less you breathe out, well, the less CO2 comes out. And so more CO2 is retained in the body, which makes the body more acidic. So remember, more carbon dioxide means more carbon diacid, a very acidotic body. So naturally, decrease in respiratory rate, we have more acid from more CO2. Now we see this in patients who are intoxicated or overdosed, or even a head injury. We have low respiratory rate, so CO2 is higher in the body. And with increased respiratory rate, we have less acid, that less CO2. Like with hyperventilation from an anxiety attack, we breathe out all that CO2, so the body becomes less acidic and more alkalotic, that base. Now on the other side of things, the kidneys control two key players here, hydrogen ions and bicarb, HCO3. The kidneys regulate this acid-base imbalance by excreting more acid into the urine and retaining more base, bicarb. Kind of like a teeter-totter or a seesaw here. So in the same way, it helps to balance out acid-base imbalances here. Let's just say the body has a base or alkalosis overload. Well, it helps to balance out the body by excreting more bicarb and retaining more hydrogen ions to make the body more acidic. It does its part to help balance out the acid-base imbalance. So naturally, too much or too little of either acid or base can throw the body out of balance. If one is out of balance, well then the others will try and adjust by increasing or decreasing in order to steady out this pH level and put it in normal range. Now this concept is called compensation. So just think the body is trying to find common ground with compensation. Just trying to find that balance. But we'll cover that in a moment here. Now that we understand the basics behind acid and base, let's talk about respiratory versus metabolic acidosis or alkalosis. For metabolic, as mentioned before, acid can be found in the urine from those high hydrogen ions and also in the stomach acids, right? So what happens if the patient vomits out all that stomach acid? Well, what are we left with? Acid or base? Well, base. We're left in alkalosis since we threw up all that acid out of the body and into the potty. Now, what about renal failure? We have broken kidneys, right? So can the kidneys excrete those hydrogen ions via the urine? Well, no. So acid is retained, putting the body into acidosis. And lastly, we know that the intestines hold more base, right? So say the client has diarrhea and they poop out all their base from the body and into the potty. What are we left with? Only acid. So the body goes into acidosis. Okay, now our memory tricks are really fun here, so pay close attention. With metabolic alkalosis, we vomit out all that acid, leaving us in a base or alkalotic state. So just think alkalosis. It kind of sounds like you're throwing up with alkalosis. And you hold your stomach region, indicating that metabolic area with alkalosis. Now, this is also true with NG tube suctioning, that nasogastric tube. Again, too much acid loss leaves us in a base or alkalotic state. So the key points to write down is vomiting and too much NG tube suctioning is metabolic alkalosis. And for metabolic acidosis, we have diarrhea, renal failure, and DKA, that diabetic ketoacidosis. So for diarrhea, you poop out all of your base, right? Which leaves the body in acidosis because only acid's left. So just think, if it comes out of your acidosis, well, then you'll be in metabolic acidosis. Thank you guys so much for watching. Please be sure to download your cheat sheet study guides as well as take the quiz on.
All right. So, so the next section, we're going to finish this PowerPoint off with just talking through ABGs and that sort of stuff. So it's important to remember that, just as a rule of thumb, in the real world, in the practical sense, all of our cellular metabolism waste products are acidic. So everything we do cellular metabolism wise is a waste product. And so typically you're more likely for someone to end up in an acidotic state than an alkalotic state. It's more likely someone will go into acidosis than alkalotic. So I'm going to save some of these for in-class time so we can kind of talk through ABGs on that time frame. So I'm going to stop the lecture here. Thanks for listening. Look forward to seeing you guys in the next one.